I'd like to thank the SAGES Program Committee as well as the session moderators for giving me the privilege of the podium. I'm going to take several minutes today throughout this talk to discuss the role of laparoscopy in the management of perforated diverticulitis. The following are my disclosures. The incidence of perforated diverticulitis is actually quite low. It's about 3 to 4 per 100,000 cases per year. However, when it does happen, it's extremely morbid and lethal. Resection, which is often the choice for management, is associated with a significant amount of morbidity and mortality, with complications ranging anywhere from 30 to 50%, as reported in the literature, with mortality rates ranging anywhere between 10 to 20%. Often, management is dictated by what's found on imaging. Standard practice is to resect and create an end colostomy. Unfortunately, this ends up on the other end, leaving a lot of patients with permanent colostomies. And then, of course, there is the increased morbidity that's associated with colostomy reversals. Recently, there's been, I would say probably over the past 10 to 15 years, there's been growing interest over minimally invasive approaches, laparoscopic lavage, and single-stage operations in select patients. To truly understand the role of laparoscopy in the setting of perforated diverticulitis, I think we have to have a clear understanding of what patients would potentially select out in terms of not being good candidates for minimally invasive surgery. In particular, I think obviously patients who are stage 1 and stage 2, these are not the patients that we're discussing, and unfortunately a lot of the studies that I'll be presenting don't really classify or have a difficult time classifying or sometimes even including some patients that are not necessarily considered to be perforated diverticulitis. I think for the purposes of this presentation, I'll be focusing on patients who present with stage 3, which is classic stage 3 perforated diverticulitis with gas and liquid discharge, not stool discharge. Clearly, the patient clinical status as well as findings on imaging will dictate management. For example, in these two different CAT scans, the management was quite different. The image on your screen left has a localized abscess, which was drained percutaneously, whereas the image on your screen right shows free intraperitoneal air requiring emergent exploration. Of course, we all understand and appreciate the indications for emergent surgery in the setting of perforated diverticulitis. I'm not going to belabor this point. The purpose of this slide is to really demonstrate the wide range of options which are available for management, and they range from the classic resection and colostomy to resection with primary anastomosis with or without a proximal diversion, to peritoneal lavage, and then finally proximal diversion without resection of the disease source, which of course is not a favorable option as it leaves the septic source behind. With the laparoscopic skills improving and more data coming out, a lot of these procedures are being attempted laparoscopically, and the remainder of this talk will be spent reviewing primarily peritoneal lavage and laparoscopic approaches to segmental resection. Laparoscopic lavage was first introduced out of Ireland back in the early 1990s. And the initial reports were actually encouraging. At least the appeal of it was that it decreased morbidity and mortality with faster recovery of the patient. The procedure itself was quicker. There was the opportunity to potentially avoid a stoma with less wound and anastomotic complications, and of course the obvious fear of avoidance of permanent stoma. The primary critique of it was, of course, that it left the septic focus in place. The Dutch Diverticular Disease Collaborative presented their early experience with lavage in 2013. They included patients that underwent lavage between 2008 and 2010. And they only included patients, and this is critical, with purulent peritonitis or distant free air. They included a total of 38 patients, so it's not a huge sample size, but of these 38 patients, 18% or 7 patients developed uncontrolled sepsis, 13% required a reoperation during the study period, and 5% died of multi-organ failure. And they concluded that while laparoscopic lavage is a promising technique in the setting, in the sense that it prevents increased morbidity and stoma rates and permanent stomas, it is still associated with increased morbidity and mortality, particularly in patients with uncontrolled sepsis, and therefore should be considered in a very selective fashion. This study was followed shortly by the Scandive randomized controlled trial in 2015, which evaluated the superiority of laparoscopic lavage to colon resection in patients with perforated purulent diverticulitis. The study was designed as a two-group, open-labeled, pragmatic, superiority, multi-center, randomized controlled trial involving 21 centers in Norway and Sweden. The patients were randomized pre-op, and Hinchey grade was assigned intra-op. The Hinchey 4 patients automatically underwent a Hartmann's procedure. The measured outcomes were, at least the primary outcomes, were severe complications at 90 days, and the secondary outcomes were length of OR time, length of stay, postoperative complications, reoperations, and 90-day quality of life. They, in reviewing their results, they found that there was no statistical significance in severe complications between the two groups. Within 1 year, the lavage group was associated with a greater need for reoperation. It's almost a 2-to-1 ratio. And the lavage patients were noted to actually have shorter OR time, which is would be expected, less blood loss, and less stoma rates for the shorter follow-up period. The limitations of this study were pretty significant. It was the randomization occurred after exploration, so there was certainly a risk of selection bias, and patients that had higher ASAs were not enrolled. In reviewing this paper, the conclusion suggests that there are advantages for lavage, but that those should really be weighed against the risk of secondary interventions, particularly in patients with ongoing sepsis. I think the study that brought to light the potential limitations of lavage was this study out of France, which was published in 2015 in the Lancet. This was a study aimed at determining the superiority of lavage to sigmoidectomy with respect to long-term morbidity and mortality. This was a multi-center parallel group randomized open-label trial with 2 different arms, a lavage versus resection arm, and then a Hartmann's resection versus primary anastomosis arm called the DIVA arm. Patients were included who had evidence of free air or fluid on CAT scan, and for the LOLA group, or the lavage versus resection group, only the Hinchey 3 group was included. Diagnostic laparoscopy was used to confirm the presence of purulent peritonitis, and there was a 2-to-1-to-1 randomization, with the primary endpoint being major morbidity and mortality within 12 months. The trial was terminated prematurely for primarily safety reasons. There were high short-term morbidity and reintervention rates. there was increased major morbidity and mortality with regards to lavage. At 30 days, the composite primary endpoint was higher with lavage, with higher reintervention rates in lavage. And at 12 months, however, there were no differences between the composite primary endpoints. The study concluded that lavage was not superior and did not really reduce the composite primary endpoints. There were higher acute reintervention rates. But it did also demonstrate that those patients that failed lavage and required salvage resection did not necessarily experience increased mortality. Of course, what is somewhat a bit confusing regarding the role of lavage in the setting of perforated diverticulitis is that there are studies that do show that it does have a benefit, particularly the Delilah study or the diverticulitis laparoscopic lavage versus resection study, whose aim was to look at 12 and 24-month outcomes of lavage versus Hartmann's procedures. This was a one-to-one randomized controlled trial with inclusion criteria being CT evidence of fluid or free air, and intraoperative randomization if Hinchy 3 was confirmed. And the primary outcome was reoperations within 24 months. The strength of the study was that it's randomized during laparoscopy and there was no post hoc subgroup analysis. And they essentially were able to randomize 83 patients after laparoscopy. And they identified, again, as has been shown by previous studies, that the lavage patients had a shorter operative time. They also were able to demonstrate that lavage was safe and feasible with really no differences in mortality or readmission rates between the two arms after 24 months. In fact, one of the main things that really stood out was that the number of patients that required a stoma at 24 months was significantly less in the lavage group than the Hartmann's group, albeit the numbers are quite limited. In fact, multiple meta-analyses have been published hoping to clarify some of the contradictory results of these published studies. I've listed all the meta-analyses that I could find up to this point looking at lavage versus Hartmann's resection, and really falls into two camps, those that favor and those that are against. And a lot of these, interestingly, use some of the same source data. So it likely, at least the differences likely, are secondary to inclusion criteria that were used for these individual meta-analyses, the time points that were selected, and the designated endpoints that were selected. In summary, with regards to lavage, the currently published trials are somewhat limited by sample size, selection criteria, differing techniques that were used, and design flaws. Pooled analyses, of course, are based off of these studies and therefore have somewhat mixed results for the reasons that I mentioned. Certainly, cost analysis does favor lavage in the sense of what is required for stoma management with regards to care and the cost of reversal surgery. But the presumed benefits of lavage must really be leveraged against the morbidity of reoperations and ongoing sepsis. And finally, the studies that have been performed have generally excluded feculent peritonitis, which is in a different category in and of itself. The recent practice guidelines published by the American Society of Colorectal Surgeons Clinical Practice Guidelines Committee addressed this specific topic, and this was really based on strong, high-level, high-quality evidence, level 1A evidence, that in patients with purulent peritonitis, colectomy should be the preferred technique over lavage, that laparoscopic lavage is associated with higher rates of secondary intervention in comparison with colectomy. I encourage you to look at this and review this new practice guideline that was just recently published in the diseases of colon and rectum. Well, what about the role of laparoscopic segmental resection in the setting of perforated sigmoid diverticulitis? In some aspects, you could argue that it may actually be technically easier to perform this procedure laparoscopically than open, or that it would be easier to perform this laparoscopically than it would be for someone who has, let's say, stage 2 disease. The mesenteric dissection may be less challenging because of less edema and chronic inflammation. The anatomic planes would be less distorted because there's really less time for exposure to free peritonitis. There's also less time for the omentum and surrounding organs such as small bowel to adhere to the inflamed region, making it a much more challenging and difficult dissection, and it allows theoretically for easier access to subdiaphragmatic areas for evaluation, as well as deep down in the pelvis in the pouch of Douglas for lavage. And finally, there's the potential, of course, as with all minimally invasive procedures, with less trauma and tissue damage. The expected advantages of laparoscopy in the emergent setting are very similar to those that have been identified in the elective setting. I'm not going to belabor this point other than to say that the negative aspects of laparoscopy, or the potential challenging aspects, are that the high level evidence is lacking. Most of the data that I'll present in the upcoming slides are really just data which are based off of single institution retrospective data. The operative time is certainly longer, and the technical expertise needs to be higher because of the requirement of the ability to thoroughly inspect all portions of the abdominal cavity, if at all possible, and of course to avoid injury. This study, which was published in 2016, looked at the role of laparoscopy in perforated diverticulitis in comparison to open sigmoidectomy, with the aim being to demonstrate any changes in morbidity and length of stay between the two groups. This was a propensity matched analysis run parallel to the ladies' trial out of 28 Dutch academic centers between 2010 and 2014, and there was a cost analysis performed as part of the study. They did demonstrate that while the duration of the surgery was longer, pretty much all the other endpoints, such as Hartman's, primary anastomosis, ileostomy rates, were very similar. The in-hospital overall morbidity was significantly less in the laparoscopic group, and the severe morbidity, although it did not reach statistical significance, was also less. Obviously, the study was limited by its retrospective nature and the fact that there was significant selection bias. They concluded, based off of this study, again, with these limitations in mind, that laparoscopy can be favored in this setting. However, the results should be tempered because of the selection bias and the fact that the surgeons that were operating were experienced laparoscopists and GI surgeons. A very recent pooled analysis suggests that there may be an advantage to laparoscopy in the setting of perforated diverticulitis with regards to resection. But again, the results of this should be tempered by the fact that the studies that were included were generally poor quality single institution or studies with small sample sizes. This particular study included these four studies that have looked into the role of laparoscopy or laparoscopic resection. Again, most of these are retrospective, and a couple are propensity matched analyses with varying sample sizes. They essentially demonstrated that with laparoscopic resection, the 30-day mortality is at least not significant from open resection, not significantly different from open resection, but that these 4 studies did demonstrate an overall decreased postoperative complication rate. In summary, the literature on laparoscopic approaches for resection in the setting of perforated diverticulitis is still maturing. The majority of the studies that are included do not really specify Hinchey level or they do not separate out the Hinchey levels quite well. The data is generally poor quality, and there are patient and surgeon factors which are certainly critical to the outcomes. Overall, I would say that the jury is still out on this. In conclusion, with regards to lavage, it really should be used judiciously in select patients. There is a significant risk of unresolved sepsis requiring ultimately a secondary intervention based on some of the more recent reports. And certainly further studies are necessary to identify the selection criteria for patients who may benefit from lavage, and to also really standardize the operative technique, which has been one of the major flaws between some of the major studies that have been performed. With regards to laparoscopic colectomy, early studies have certainly shown promise, but most are limited by poor quality. There are theoretical advantages in select patients where chronic inflammation has yet to settle in. However, the data is really not sufficient enough to fully support the use of laparoscopy in the setting of perforated diverticulitis, and certainly more robust studies are necessary. Thank you again for your attention.